All right, welcome. We are going to do our case presentation demonstration of clinical competency using WM. So that's not what I wanted to do. Let's go back to the beginning. Okay, so this gentleman came to UK. He was a transfer from an outerlying hospital. And he was presenting with a chief complaint of some lower back pain and dysuria. He was found to have severe hyponatremia at the outside hospital, as well as worsening renal function. And in the setting of kidney transplant in 2007, he was sent directly over to UK. So he wasn't really at the outside hospital for too long. We evaluated him for admission, and he was a very pleasant individual, providing answers to all of our questions. He was our chief informant. And he decided it was time to go to the emergency room when his back pain just continued to get worse despite his use of Norco to help mitigate that. He noticed his urine was becoming a little more discolored. Not a real drop in amount that he noticed, but it was cloudier and darker. So he felt like it was time to come in. Hadn't really had this problem before. And hadn't really been hospitalized at all. So had been living pretty well and independent. History of present illness includes unilateral kidney transplant in 2007, so one functioning kidney. Baseline creatinine is around 1.5, 1.6 or so. So he had cloudy, dark urine for 2 days, dysuria, back pain increasing and becoming worse, some dull, achy back pain to the mid-back, progressive dyspnea as well over the last couple months, and abdominal and lower extremity edema, especially the lower extremities. So we've got a lot of volume retention going on, and but denies any kind of other cardiac symptoms, palpitations, dizziness, syncope, chest pain, etc. None of that. So, looking at the records from outside, sodium 114, potassium 5.2, creatinine a little worse than baseline. Wouldn't really call that AKI, although he does develop that by the time that we see him. His creatinine was up further, I think 2.25 or so. Chest film, bilateral pleural effusions, that's all we had heard. That was from an outside record, though. So, of course, we were going to repeat our own, but that's what we have to go by so far. Other records, past history, hypertension, etiology for his kidney transplant, no recent hospitalizations, utilizes his primary care, does have an aspirin allergy, evidently has urticaria associated with that. Moving forward in the social history, and you might notice at the bottom, I decided to try to take the DMP Essentials and the other standards, AACN standards, as well as the NOP competencies, and just make a little note on the individual slides where I thought that they might be applicable. There's definitely areas, certain ones that cross over to different components of this case study. But just for prime examples, I made notes at the bottom of certain slides. So you might see that here. In this case, the DMP essential number 1 is the scientific underpinnings, and part of that describes nursing as focused on patterns of human behavior in interaction with the environment and normal life events, and wholeness of human beings. And I thought that the psychosocial history and sort of developing a rapport in having this discussion about these things sort of contributed to the demonstration of that essential. So you probably read what's on the slide by now while I was going on about that, but lives alone, independent. This is a 75-year-old man who's relatively um, large. His BMI, I think, was 39. So he's been retired for quite some time. You know, just a hefty, solid dude. Yeah, high school educated. History of alcohol consumption remote. I come to define that a little more thoroughly after I see him again later, but I kind of left it at that when during the initial interview. But he said he hadn't really drank since 1999, but had drank up to a case a day for 10 years prior to that, in addition to some other heavy drinking prior. So does have a positive history there. Some smoking history as well, and did have a father who died from lung cancer. Denies any kind of illicit drug use. Medications, these are his home meds, came from the pharmacy that he fills his meds at. Jumping down the list here, he's got the anti-rejection type meds. It has some underlying rate control. Basically, he takes carvedilol, but he has rate controlled AFib. And so he takes the apixaban for that. Furosemide, I have a question over here. How much furosemide? Is because he is one of those guys who is under instruction by his primary care guy to, if you notice a little bit of edema starting to develop, go ahead and take an extra 40 that day. So with that in mind, and with his gross volume overload that he demonstrates right at this presentation, he may have been taking another dose from time to time, so even up to 120 a day. And I think that's pretty significant as we see his renal function is worse than it is at baseline. And despite the use of these oral diuretics, he's still quite volume overloaded. Other things here, also takes an ACE. So we're gonna in our plan, you'll see we're gonna hold that in the setting of his kidney function. But I put is there treatment for heart failure because it looks like through that regimen that maybe there is. Don't have like a specific, you know, knowledge of him having heart failure, be treated for heart failure. Maybe these are just being utilized as a hypertensive type regimen. But it kind of made me think about heart failure, as did his physical exam, which we will get to. Okay, review of systems, NOP6, that is the independent practice. So kind of starting to get into where we're, using advanced assessment skills, developing diagnostic strategies, that kind of thing, and further developing our relationship as I go through the interview and talk to this guy and actually do his physical exam. So has a lot of weakness and fatigue, weight gain. Mentioned that he's quite volume overloaded, so that makes sense. Dyspnea with exertion. He's also got 3 to 4 piloorthopnea. Using nasal cannula all the time now, which is different than baseline where he's on room air. Is not having any trouble oxygenating as we see through his vitals and lab values and things, but he feels better with it, and it's of course more related to dyspnea versus an oxygenation type issue, probably related to his volume status. Cardiovascular, progressive lower extremity edema, history of AFib. Evidently had a little bit of diarrhea. I didn't, really dive into that too much further. But yeah, I think at this point that he presented, he said things were normal and had been for the last couple of days. So didn't pursue that too much. Cloudy urine, some pain with that as well as the back pain. No history of thyroid disease or other hematological issues. Physical exam, just wanted to point out this blood pressure is on the low side. Not exactly sure everything that's contributing there, probably partially medication induced. maybe infection related, but, doesn't really look infected in any other way. He's not tachycardic, although he takes beta blockers. He doesn't have a temperature. He doesn't seem or look to have more of a systemic type infection or syndrome going on. Pertinent findings from the physical exam: he is neurologically in pretty great shape, making jokes and whatnot, carrying on with us. Prominent JVD, estimated it at around 12. It was noticeable. You could see it from a distance, and so that was significant. I mentioned already he had a very difficult time laying down at all. He was sitting, really upright in the chair when I first met him. Not labored at all, or not distressed at all. A little bit labored in his breathing, but comfortable. But he wasn't wanting to lay down at all. Crackles bilaterally, irregular rhythm that I could palpate, and a systolic murmur that I heard, probably tricuspid regurg is what I thought, related to his volume status, and his edema was profound, 4 plus mostly, down in his lower extremities, certainly from the knee down. Thighs were a little more firm, but still pitting. They were probably 3. And then edema throughout his abdominal region that it was sort of hard to tell how much was his body habitus and how much edema was actually there, but he described it as having fullness, and he certainly felt taut. So less noticeable in the upper extremities, but probably just because it was so profound in the lowers. Could still get up and ambulate and move around okay, but it was definitely inhibiting him. So also, discoloration with the lower extremities, indicating that this is probably a chronic issue to some degree. So there's that as well. Some more essentials that I covered here. I think this is the advanced nursing practice, and so involving assessments, designing, implementing interventions, things like that. So we're starting to cover more with each component of the workup here. Diagnostics that we kind of initially put in place, including lab values, which we'll see next. But the chest X-ray that we got demonstrated some right hilar congestion, diffuse edema, bilateral pleural effusions, although they were pretty small, not overly significant. But I think the main thing here is that we could see some, signs of volume overload, but no real cardiomegaly. And I thought that was, I was looking for that because I thought that there might be some element of heart failure going on. Renal ultrasound, kind of always indicated in a situation like this, and currently, especially with the transplant history, mostly trying to evaluate for hydronephrosis, which he didn't have, so kind of ruled that out. The echo, EF, preserved, moderately dilated LV, I'm thinking probably related to volume, and really dilated RV systolic pressure 60 to 70. So JVD, right heart pressures, peripheral edema. So definitely some right heart failure for sure happening, congestion here. LV seems to be, kicking out the blood. So probably less of a perfusion issue impacting the kidneys. However, he's taking his hypertensive medications and may have had some hypotension that contributed to his kidney injury as well. I don't know. I didn't know exactly how to elucidate that more specifically, but also we do have the infection and a reduced GFR at baseline. So we probably have some infrarenal as well as some prerenal involvement going on, but I'm sort of jumping ahead, so let's jump ahead. Labs. So the ProBNP, maybe not as interesting to see now, especially after we looked at that echo. I mean, I guess this supports his volume overload, which, we have a lot to support that now. What do we have? K is a little worse. BUN and creatinine are a little worse. Glucose is fine. Um, we do have pancytopenia and certainly some low platelet levels. So important to kind of check this out as well, that the other LFTs or your typical set here all look normal. Does have an elevated INR, but he takes apixaban as well. So kind of, wondering about his liver a little bit. And so let's go ahead and move forward. Urinalysis, what we thought, and so we are going to give him antibiotics. Let's jump over to the list. Now we're going to satisfy a lot of the standards here, because this gets into all the synthesis, differential diagnosis, implementing a plan, and creating some interventions to try to help our fella here, Mr. WM. So, all right, we've got the kidney-related issues, I guess, right here as his priorities. Um, you know, uh, Acute kidney injury, I did call it that at this point because he did end up developing, worsening numbers from the outside hospital to where we were dealing with him. Has an infection, started antibiotics to cover that, IV ceftriaxone. We're going to hold his ACE inhibitor in the setting of his injury, and assuming that things resolve, and we do have to consider his hypertension at some point, probably a better agent for this gentleman, given his kidney function and his age. Maybe try a calcium channel blocker or something like that. Um, so definitely want to monitor for worsening signs of infection, developing a fever, having low blood pressures, these kinds of things. Is definitely a guy who uh, I would not want to give him any more fluid. In fact, we're going to restrict his intake down here and try to deal with this hypervolemic situation. So, of course, we want to include the transplant team in our workup and evaluations. They know him from the clinic, things like that, and especially with his immunosuppressants. Of course, that's something you can pretty much never really stop, even in the setting of an acute illness, or a situation like that. Um, but this guy's very stable overall. However, these are nephrotoxic type agents, so it could be that there might be a dose reduction or something like that these guys could help recommend for us. Was the thought. So hypervolemic hyponatremia. That seems. I thought that seemed pretty obvious as to what was happening here. Not that it was a sodium issue, but that it was a volume issue. And so, the diuresis is certainly the intervention number one that I was thinking of overall for this patient. Wanted to try to start conservatively with a 40 milligram IV bolus just to see how that affected him, trying to keep it, on the lower side. We did that, didn't have much of effect. Actually, didn't try to escalate doses, just jumped over to Bumex and responded really well to 2 milligrams. He ended up getting 2 milligrams BID for multiple days, and had really good effect with that. Fluid restriction to help check the urine osm, and the thought on that was just to try to kind of confirm that it was a concentrating, decreased concentrating ability in the nephrons, and so renal sodium retention was causing water retention, and the hypervolemic state was ensuing. As I mentioned earlier, not exactly sure, to what degree maybe a renal perfusion problem was also going on, maybe perpetuating ADH secretion and getting that whole feedback loop involved and causing worsening fluid retention. Um, However, a cortisol deficiency would also perpetuate that ADH, so we're just kind of going to rule out that and rule out the hypothyroid as a causative agent for his hyponatremia as well. We're also going to, of course, want to watch his eyes and nose really closely and make sure we're in the negative. I think we set him at a -1 liter goal for that first day, a little bit conservative, and just see how things, hopefully, if things started to turn, which they actually did, we could kind of ramp that up, which is also what happened. Okay, so now we have the heart failure, HFpEF, preserved ejection fraction picture. Again, diuretics, best thing for it. And I think that we didn't actually do this as I looked back later to see what his discharge was, because I only ended up seeing him just this day and the next day, at admission and the next day. But I definitely thought that a repeat echo once we reached like euvolemic state would potentially be important to kind of really get an evaluation of the degree to which he was experiencing heart failure and try to maybe manage that better or as ideally as possible to prevent his cardiac condition from worsening, and also his renal function from worsening just from his cardiac function worsening. So anyways, diuretics still therapy numero uno in this situation as well, and watch for worsening symptoms like oxygen requirements increasing as hypervolemia maybe could get worse. So of course that was not going to be the goal, but I think that was kind of the main thing here. Still seem to have appropriate perfusion, palpable pulses distally and things like that, despite after you can kind of push down through the edema. But daily weights seem to be appropriate to kind of just give us some more information that we were indeed reaching our diuretic therapy goals. Pancytopenia. So this one was a little bit more complicated for me. I hadn't really done an anemia type workup before. It seemed likely that to me that this was anemia related to his renal disease. Not only were his H&H low, but his red cell count was low. We did a retic count low. We actually did the rest of the workup as well: ferritin, transferrin, saturation, and B12 and folate. And really, the ferritin and transferrin levels being on the lower side, the ferritin 380, transferrin sat 26%. Those were low enough to indicate that an iron supplement could be started, and that was going off of the 2012 National Kidney Foundation guidelines for people with chronic kidney disease that were non-dialysis dependent. Seems easy enough. Start some iron and evaluate in a few months and see if the H&H is coming up. And really, a lot of that, why would you want to do that? It seems like it may not be indicated, or what is the indication? But just weakness and lethargy and things like that people experience with lower hemoglobin levels could be mitigated by trying to keep those levels elevated a little bit. I think the FDA has set that number at 10 to 11 and a half as a goal. So this could be a guy that you could also consider EPO on. I learned from the guideline as well. So erythropoietin you evidently don't want to start when there's some inflammation happening. So in the acute setting, probably not the greatest idea, but it was an interesting thing to consider, and especially if the iron supplementation wasn't really helping him to a significant degree. So anyway, that's the kind of anemia side of things. But other than that little bit of workup, the thrombocytopenia was a little bit more perplexing, and it was pretty low. His platelets were in the 50s, and so I looked at a lot of his drugs that he was taking, things even like his statin his apixaban. Some of these things have thrombocytopenia as a side effect. Not sure if that was what was going on, but evidently, even as few as 6 or 7 years ago, on the same types of medication regimen, he had higher platelet levels. So, thought that maybe given his past history, maybe there was some liver involvement. So we decided just to do an abdominal ultrasound to kind of, non-invasively and with low impact, try to work that up a little bit. Hypertension, a problem that we currently weren't managing, but still a problem of his that we wanted to make sure that as things hopefully started to turn around, we would maintain what the JNC8 recommends as far as a blood pressure goal, and monitor with potentially different agents, as I mentioned earlier as well, and monitor for the effects of diuresis and medication changes. So potentially lowering his blood pressure, and medication changes potentially raising his blood pressure. So I wanted to kind of, acknowledge that that was still an ongoing thing for him. Okay, so we basically tuned this gentleman up pretty well with diuretic therapy. Ends up getting diuresed like 11 to 12 liters. Still has some pretty significant edema in the lower extremities. So, got sent home on some oral Bumex as well, taking that 2 times a day. And actually did have some nodularity on his abdominal ultrasound of his liver. Some heterogeneous texture, or something like that was how it was described. Let me see, I think I have it right here. Heterogeneous echotexture and diffusely nodular. I looked at it, and that was very difficult for me to actually be able to extract out of those images. But I did look into it to see some of what the information is out there on nodularity, and it has been described as sort of nonspecific. However, there is no actual gold standard definitive diagnosis for a new cirrhotic. Even doing a biopsy, it really depends on where you would obtain that biopsy from. So if you get it from a section of the liver that doesn't have isn't fibrotic, then it might not show you that there is actually cirrhosis present. So even if you got the ultrasound, the biopsy, and you see that the albumin and the synthetic function is poor, low platelets, it's kind of a constellation of symptoms that lead you to an actual cirrhosis diagnosis. So with his blood work, and the ultrasound, we did arrange a hepatology appointment for him, and hopefully as an outpatient that could be worked up a little bit further, or at least be on the radar as he gets a little older, and maybe potentially has issues with that, or maybe not, hopefully not. But heart failure and cirrhosis could definitely contribute to his worsening kidney function over time. So it seems like his history, having renal disease, and his future with his comorbidities are probably going to lead him to worsening renal function over time. So that seems to be the case of this gentleman, but he did do really well for us, and he did end up leaving the hospital. I think I think he came in May 16th and left on May 24th, I want to say. So he did. I felt like he did really well, and he progressed each day. As I read through his notes to kind of see how our plan of care worked out for him. So. Yeah, I felt good about it. So that's Mr. WM. Thank you for this opportunity to learn how to do a video presentation.